Professor Ali Museni. Thank you very much, Professor Ali Museni, for this sophisticated presentation. And we hope to see you next year in Cairo. Thank you again. Now I have the honor to introduce Professor Men'em Wahidi, who will present to us bronchoscopic ablation of lung tumors.
Hello, everyone. This is Dr. Men'em Wahidi. I'm a professor of medicine at Northwestern University, Feinberg School of Medicine in Chicago, in the United States. I'm an interventional pulmonologist, and it's my pleasure to be here with you today at the annual meeting of the Egyptian Society of Chest Disease and Tuberculosis. I'm honored to be talking to you today, and I will be discussing advances in bronchoscopic treatment of peripheral lung tumors. Why does this topic matter? Because we have a big vision for our patients. So imagine this scenario. You have a patient who was a smoker in the past, who now presents to the office with a lung nodule suspicious for lung cancer. The patient is not a surgical candidate. We do a PET scan, and that nodule is FDG avid, and there's no other FDG activities in the chest or anywhere in the body. So the vision is then the patient comes back the next day, you do a bronchoscopy, you do navigation and radial guided bronchoscopy, you sample that lung nodule. And then the pathology team can give you a rapid on-site evaluation results and tells you that this is adenocarcinoma. You also perform linear nevus staging of the mediastinum, and you find no enlarged lymph nodes. And you can proceed right away in that same procedure, that same sitting, to do treatment of that lung nodule with an ablative therapy because the patient is not a surgical candidate. So you can imagine the convenience for the patient and the efficiency of the procedure that is diagnostic, staging, and treatment. But how close are we to that vision? That's what I'm going to review with you today. So we all know the overall survival of lung cancer by clinical stage, as you see in this graph. You can see that stage 1 and 2, the survival is anywhere between 53% to 90%. And so, that's why it's really important to detect lung cancer in early stages and offer the best treatment for these patients. And we know that for early stage non-small cell lung cancer, the best treatment is surgical resection. Whether that's a wedge resection, a lobectomy, a segmental resection, lumenectomy, or even sleeve lobectomy if the cancer is involved in the airway. So surgery has been the standard of care. However, not every patient we see with early stage non-small cell lung cancer is an operable candidate. The British Thoracic Society and the ACCP guidelines have addressed this issue and recommend that you do spirometry BLCO on every patient prior to lung resection. The BTS guideline says that you need a minimum FEV1 of 2 liters for lumenectomy and a minimum of FEV1 of 1.5 liters for lobectomy. CHEST guidelines suggest that we estimate the predicted post-operative pulmonary reserve by estimating predicted post-operative FEV1 and DLCO, and they have to be more than 60%. If they're less than 60% predicted post-operatively, you need additional testing, perhaps a cardiopulmonary exercise test. So what do we do when the patient is non-operable? We resort to other options, other treatments. So the main treatment today is radiation therapy in the form of stereotactic body radiotherapy, SBRT. We have also some options of percutaneous thermal ablation with RFA, microwave ablation, cryoablation. However, these treatments have not been studied extensively and therefore are rarely used. And now we're going to talk about emerging bronchoscopic techniques. So what are the available bronchoscopic technology? All of these are under investigation, but we have radiofrequency ablation, or RFA, microwave ablation, photodynamic therapy, cryotherapy, vapor ablation, and brachytherapy. None of these approaches are mature enough. We have some human data that I'll review with you, and we'll see where we are in those various technologies. All right. Well, let's ask the question first. How does the bronchoscopic approach to treating a stage 1 lung cancer that's non-operable different than SBRT, the radiation approach? Well, bronchoscopy is probably cheaper. In the United States, serial treatment of SBRT costs around $40,000. Bronchoscopy would be one session. SBRT typically requires 3 to 5 sessions. And with bronchoscopic approach, there's no risk of radiation pneumonitis. How about bronchoscopic versus percutaneous approach? Well, when we do bronchoscopy, there's extra risk because we are giving the patient anesthesia. However, there is a safety component in the fact that bronchoscopic approaches cause a lot less pneumothorax, probably in the single digit, 1 to 4% or so, while percutaneous approaches have a higher pneumothorax rate. The one disadvantage of bronchoscopic approaches is that we're not yet great at reaching the lesion. So when you do a CT-guided percutaneous approach by radiology, they're able to reach the lesions in 90% of the time or so, or higher. With our bronchoscopic technology, we're able to reach the lung nodule tumor in 70 to 80% of the lesion. So it's not guaranteed you're going to be there. That's a really important aspect of this procedure. And therefore, we need to have a CAT scan to confirm that we're there. So these are the challenges of bronchoscopic ablation. Again, we don't always reach the target. We need to make sure that the catheter, the ablation catheter, is positioned in a location in the target that can ablate the whole tumor. And for that, we need, again, real-time CT scan confirmation. Those are cone beam CTs typically that can be fixed in the operating room, or now we have mobile CT. And then lastly, predictability of the ablation zone. So we don't have enough information about energy, the wattage, the location of the probe in the lesion to say that we always can predict that kill zone. It's so important to treat cancer with a margin around. All right, here's an image of confirmation by cone beam CT. So in image A here, you can see the bronchoscopic tool is at the lesion, and the catheter, the ablation catheter, is out. But we had to confirm that with CT scan, cone beam CT. You can see the sagittal, coronal, and axial images showing that the catheter is within the lesion. And so this is a confirmation we need to potentially deliver the ablation in a precise way. Let's talk about the data. What data do we have today that there's bronchoscopic approaches to ablation in the periphery work? So I'll start with the first study that was published in 2010 by the Japanese group. They took 10 patients with stage 1A lung cancer and used 3 different catheters, the RFA catheter, and what they found that it's kind of pretty intuitive that if the ablated area were treated with a local probe, they had much vision. And obviously, if you put the blade for longer times, again, the ablation was larger. Interestingly, the resected tissue, so they treated the patient and resected the lobe, showed that all these treated nodules, tumors, had residual tumor in it. So clearly, at that time, we were not sure the energy needed to really ablate all the tumor cells. There was no complication in this preliminary study in 2010. Same group treated more patients, followed them longer, and followed them for 5 years. And they did report that there's local disease control in most patients, 82% is based on imaging. And then the 5-year survival was 61.5%. This compares favorably, obviously, to surgery. And there were minimal complications encountered. 3 patients had some fever and chest pains, managed conservatively with short-term hospitalization. So this was very promising early data on the use of RFA. And one thing the study highlighted is the changes, the radiographic changes of these nodules on treatment. We're not used to seeing this as pulmonologists. So you can see here in the top panel, in image A, you see that ground glass nodule that was treated. This is before treatment, and then D and C is the follow-up CT 6 months later, 24 months later. You can see it's become more of a linear opacity. But in the bottom panel, a patient that was treated with RFA, this is image A here, before RFA, kind of lobulated nodule. Patient comes back, chest pain and fever, and you can see all this consolidation now, 2 weeks after the RFA. Again, it's not clear if it's an infection or just an expected changes. It appears that these were just expected changes after treatment, because you can see on subsequent CTs that it's going away, these infiltrates, and it's becoming more of a linear scar. So one thing we need to learn is how do these lesions behave after the treatment. And then a more modern day experience, it's coming actually from Hong Kong, Dr. Ng, Dr. Lau in the UK, and this is their first report from Dr. Ng, a retrospective analysis of a single center experience. They're using electromagnetic navigation to get the nodules to the nodules and then confirm with a cone beam CT. They did 31 nodules from 25 patients. They did report technical success in 100% of the time, meaning that they were able to get the catheter to the nodule, the tumor, and then treat it with the ablation. They hospitalized the patient for a mean of 1.73 days. They had some complications, pain in 13% of the patients, pneumothorax requiring chest tube drainage in 6.67% of the patients, and some post-ablation reactions in 6.67% of the patients. At 12 months, no nodule had evidence of progression. So this is more of a feasibility study showing safety and early data on efficacy. Again, the patients have not been followed for 5 years, so we don't know the kind of the local recurrence or distant recurrence yet. And then another report just recently from the Journal of Oncology, Interventional Pulmonology in 2023 from Dr. Lau. And you can see this time they use microwave ablation, not RFA. Again, patients who have malignancy less than 3 centimeter max in diameter, patients not candidate for surgery or SBRT. Again, they did electromagnetic navigation bronchoscopy confirmed with cone beam CT, as you can see in this image, the CT showing the catheter within the nodule. They did say again at 1 month there was 100% technical technique efficacy, meaning that they were able to see ablation changes on the CT scan. But again, we don't know any data yet about how the patients did, is there any recurrence, survival. And the adverse event rate was acceptable at 3.3%. One patient basically had mild hemoptysis. So you can see that we have data and some data, early data, mainly safety, a little bit of efficacy, but not long-term data. A lot of this is coming from Hong Kong and the UK. In the United States, we have not had really great results or studies. We have no current active radio frequency ablation studies. We have one microablation study, a multi-center 40-patient study that started in 2018. Unfortunately, there was a death in 2019, which led to the suspension of the study. I'm told that the study resumed again earlier this year, and we'll wait the results. But it's a very challenging area of research because SBRT, radiation therapy, has done really well in inoperable lung cancer, early lung cancer patients. And any new technology that's going to sort of become an option has to perform as well as SBRT. And that is a really high bar because SBRT has been so effective. So the FDA in the United States, the regulatory body that's in charge of approving technology, is struggling to decide whether to allow this type of technology of ablation in the lung via bronchoscopy. I was part of a panel that attended this virtual public workshop that the FDA held last year. They invited experts in interventional pulmonology, oncology, radiation oncology, surgery, radiology, to discuss how do we get there, what kind of study do we design. And I'll just inform you of some of the discussion points and how we think the research, the evidence should be built to get there. So we really think that the best pathway to impactful data is to have a comparative study. We have to compare bronchoscopic ablation of peripheral tumors with a radiation SBRT. And those patients have to be non-surgical, deemed non-surgical by a multidisciplinary board from thoracic oncology, interventional pulmonology, oncology, and radiation oncology. The primary outcome should be local control based on imaging, but that's not the only outcome. We've got to follow the patients for many years after that, up to 5 years, and report on measures like progression-free survival, cancer survival, overall survival, safety, lung functions, and additional procedures needed and cost. And just to think about other considerations, it really, again, we should emphasize that surgery should be offered to everybody, and only enrolling in a study like this bronchoscopic ablation study if they are not a surgical candidate. We talked about multidisciplinary panel, making sure that all the opinions are heard, so these patients are getting the right treatment and enrolled in the right study. Bronchoscopic ablation is a sort of an advanced technique, so it should be done by experienced interventional pulmonologists or thoracic surgeons. And we cannot presume that a nodule is cancerous. We have to have a biopsy to confirm it's cancer, and we have to do bronchoscopy with staging or mediastinoscopy with mediastinal staging to ensure that there's no involvement in the mediastinum. And again, we must confirm during the procedure that the catheter, the ablation catheter, is within the nodule by having cone CT confirmation prior to ablation. This is mandatory to ensure safety of the procedure. So what I try to show you is where are we with bronchoscopic ablation of peripheral tumor. The reality is we're really early, and this is sort of a path that I'm showing you. My idea of where we're going to be could be shorter or longer, but just a caveat, it took SBRT 15 to 20 years to become the standard of care for non-operable early-stage non-small cell lung cancer. So it's going to take us a while. So, Doctor, I showed you some studies from Hong Kong and the UK that are publishing phase 1 studies. So that's where we are in 2023. We've done phase 1 study. Phase 1 is mainly safety. Then we need to move to phase 2 between now, this year, next year, and the following year, where we look at both safety and efficacy. So not only it's safe, but now we follow the patient for 2, 3, 4, 5 years to see has the treatment worked? Is there local recurrence? Is there distant recurrence? Once we have that information, ideally we need to do a phase 3 study, which is a comparative study to SBRT. Really, the standard of care of non-operative patients is SBRT. Could this happen in 2027? Maybe. And then finally, once we have a positive comparative clinical trial, this is where then we can really use this method of treatment freely, and then it can be included in the guidelines, because the national guidelines, cancer guidelines, chest guidelines, include only proven treatment. And so we have a long way to go. So in summary, this is an exciting treatment, exciting area of research in bronchoscopy and interventional pulmonology. We now have sort of phase 1 early data on safety. We still have a long road of proving efficacy and then compare it to the standard of care today for non-operative stage 1 and 2 non-small cell lung cancer, which is SBRT. I hope you found this educational and a good summary of the current state of bronchoscopic treatment of peripheral lung tumors. It's been a pleasure to talk to you today. I wish I could be with you in Egypt, and I hope to come maybe next year and visit a beautiful country. Thank you so much for inviting me, and have a great week.
Thank you very much, Professor Mo'min Wahidi. And we hope to see you next year in Cairo, and thank you for this contribution in our conference. Now, I have the honor to introduce Professor Sara Tomasetti, who will speak to us about cryotherapy for the diagnosis of thoracic diseases.
Good morning. It is truly an honor to have the chance to present at your Egyptian Chest Disease International Congress, and I heartily thank the organizers and my chairs for their invitation. My topic today is cryotechnology for the diagnosis of thoracic diseases, and this is my conflict of interest. We will explore the indication, the safety, the technical standards, and the future research direction for cryobiopsy in chest disorders. As you know, cryoprobe and cryobiopsy has several applications. My team and I have, for a long time, studied the use of cryobiopsy for the peripheral pulmonary biopsy in interstitial lung diseases. More recently, the same technique or similar technique has been adopted for the diagnosis of lung nodules and masses, and an EBUS-guided cryobiopsy is now emerging for the characterization of mediastinal diseases. In pleural diseases, we have less convincing evidence and more need for data, and I will show you few data on this topic. And of course, the well-known application of cryobiopsy in central airway diseases, and you know that cryoprobe is in the armamentarium of interventional pulmonologists. It has been there for more than 2 decades, and it is part of the multimodal approach to central airway obstruction. In terms of tools, in the past we have the pluri-use cryobiopsy, the cryoprobe that you can see in panel A, different sizes. Now, at least in Europe, we don't have the pluri-use anymore. We have the single-use cryoprobes. The size ranges from a minimum of 1.1 to a maximum of 2.4 milliliters. There are slightly different applications for the different sizes. For example, in interstitial lung disease, we tend now to prefer the 1.7 millimeters, and there are recent data from the Venerino Politi group for Lee Hospital showing that 1.7 and 1.9 have a similar safety and accuracy profile. Whereas the 2.4, that was the size we started use at the beginning, has been lately less used because there are some studies showing that the larger probe may increase the rate of pneumothorax. For central airway obstruction, again we use the larger size, but mostly the 2.4, followed by the other sizes. For peripheral lung nodules, we really can use any size. We tend to prefer smaller size from 1.1 to 1.9. And of course, it's worth to remember that the 1.1 millimeter cryo probe does fit the operative channel of the ultra-slim bronchoscope, which is a bronchoscope with an external diameter of 3 millimeters and an operative channel of 1.7. So it can be used for the biopsy of peripheral lung nodules. For the mediastinum, of course, the only size that fits the EBUS, the linear EBUS, is the 1.1 cryo. Now we will review some of the technique in this different scenario, and we will start, of course, with interstitial lung diseases. The technique is well established and has been standardized in several published documents, and it has also been accepted in recent guidelines for the diagnosis of interstitial lung diseases. You basically touch the pleura, retract for approximately 1 centimeter, freeze for 8 seconds if you use the 1.7 or the 1.9 probe, and then you defrost your piece in saline. This technique must be performed in patients intubated under fluoroscopy to have a proper guidance of the site. Site is very important because staying peripherally, so under the pleura, helps to prevent the tearing of larger vessels and so the risk of major bleeding. And of course, we stress the importance of the use of preventive bronchial blocker that really, in case of severe bleeding, can save the life of our patients. Of course, fluoroscopy is what has been traditionally used, but as we may know, there are several emerging guidance systems, and this is mostly a field of research that span from radio-EBUS, CT fluoroscopy, Combine, CLE, OCT, and electromagnetic radiation. And in my center, we are currently collaborating with the Danish Center, ARUS, Professor Benstrup and Sister White, for the use of electromagnetic navigation. The selection of patients is not very different from what we use, the criteria that we apply for adult bronchoscopists. There is no upper age limit, pulmonary function and coagulation are important parameters that should be taken into account. It is better to avoid patients with severe pulmonary hypertension. This is not an absolute contraindication. The HRCT guide, of course, the site of the biopsy, we select the most affected area, avoiding cylindric bronchiectasis, UIP, and emphysema. The risk of acute exacerbation should be assessed carefully before cryobiopsy in ILD, particularly in suspected IF, and patients with recent rapid respiratory deterioration suspected of having a subacute or acute exacerbation should not undergo cryobiopsy or other invasive maneuver. In terms of diagnostic yield, several studies have shown a diagnostic yield around 80%. It increases the diagnostic yield to biopsy at least two different segments or lobes, and to increase the total area of the fragments. Empirically, it is recommended to take at least 3 fragments of 5 mm each. Pneumothorax prevalence is around 9%, and the risk of pneumothorax increases when there is functional impairment, high fibrotic score, or a higher number of samples, and maybe even for the use of the larger 2.4 probes. Moderate severe bleedings occur in around 40% of patients, and severe bleeding occurs rarely, but it can be fatal, so the use of preventive blocker is of utmost importance. Current ERS guidelines recommend the use of cryo for ILD diagnosis, both in patients who are eligible and not eligible to surgery. And in case of non-informative cryo, we can step up to surgical lung biopsy. There are no data on the possibility to step up to a second cryo biopsy, and this is for sure an interesting field for research. The recommendation of the panelists were based mostly on the fact that cryobiopsy is safer compared to surgery, but also on the data of the last 10 years that have clearly shown that cryobiopsy provides the multidisciplinary team information that help the physician to correctly make diagnosis, adequately stratify prognostically patients, and make timely and well-informed treatment decisions. An emerging use of cryobiopsy is that of peripheral lung nodules. And there are several studies that have shown how to use cryobiopsy for the diagnosis of peripheral lung nodules. And there is a recent, very large, retrospective but well PS-matched study, so well-designed study, that compare almost 500 cryo to almost 500 regular forceps biopsy for peripheral lung nodules. The study showed an advantage in terms of diagnostic yield for the use of cryobiopsy, with a diagnostic yield of 89 compared to 77%, a odds ratio of 2.3, statistically significant. Notably, cryo was particularly superior to regular forceps biopsy in non-solid nodules invisible at chest X-ray. And in terms of complication, this study observed a higher complication for cryo, particularly for grade 2 and grade 3 bleeding. no grade 4 bleeding were observed in this large cohort of cases. Of course, it is important to note that there are many other studies that for the sake of time I cannot mention. I want just to show you this slide that summarizes the results of at least 5 large studies. Some of them are prospective, others are randomized, but unfortunately these studies were all conducted on small number of patients, so basically none of this would really show had the sufficient statistical power to show the superiority of cryo versus TBB. All studies in terms of adverse events confirmed that this is a safe technique that provides larger specimens compared to regular forceps TBB. And as you may know, the technique were different. Some studies used radial-EBUS, others combined with electromagnetic navigation, others with lung vision, virtual bronchoscopy. And the size of the probe used were different, 1.1 to 2.4 diameter. So the best technique is currently under evaluation. And a very interesting approach comes from East, particularly from Japan. Oki is the author that has studied and published more on this topic, and is the combination of ultra-thin bronchoscope and cryobiopsy. I will show you a case of a small nodule of the lung that we put approach in this 14 years old girl presenting with the ultra-thin scope that allowed to visualize the lesion bronchially, to perform cryo with a positive cohort for spinal cell, and then to confirm the diagnosis of this very rare tumor, myofibroblast tumor, in which we were able to do all the molecular staining needed. And it is important to note that this kind of rare tumor before cryobiopsy were possible to be diagnosed only by surgery. So just to underline how cryobiopsy is widening the diagnostic possibility of transbronchial biopsy. And in this direction goes this very interesting recent study from Park and colleague that looked at the organized evaluation, that is an evaluation used in precision medicine to choose target treatment, and they showed the superiority of drug sensitivity test and organized evaluation for cryobiopsy specimen compared to traditional technique. So cryobiopsy is also a technique that is increasing not only the diagnostic yield for difficult and rare tumors, but also the molecular diagnostic yield for lung cancer. And we know how important this is nowadays. Final mention few slides on the cryo-EBUS approach. This is a very simple technique. You perform your EBUS. After your EBUS DNA with the needle, you put your 1.1 cryo probe inside the diastole under real-time vision, and you extract your piece. And you can see how nice are the histologic specimens that you can collect using this technique. Morphometrically superior to any cytoblock or cell block that you can obtain with the needle. In terms of safety, complications are rare and of course include pneumothorax, pneumomediastinum, and hemothorax, and the most important safety measure is the use of the linear EBUS performing cryo only under direct vision and only in those cases when the interventional pulmonologist is confident to be inside the lymph node and can clearly see the probe inside the lymph node. Otherwise, when the visibility is limited, cryo of the mediastinum should be avoided. There are some studies that again are using a slightly different technique, different pulling times, different approaches to the mediastinum, needle knife or crown tip needle before the cryo, but all of them show very few complications and a high diagnostic yield. A recent meta-analysis and several data shows that cryo for mediastinal disease is superior to EBUS DNA for the diagnosis and subtyping of lymphoma, granulomatosis, and rare tumors. In lung cancer, doesn't show superiority for the morphological diagnosis, but it does show superiority for the PD-L1 and genetic panel. However, more data are needed on this topic. Pleural cryobiopsy is still a highly debated field, mostly a field for research. Meta-analysis and several studies have failed to show a superiority of cryo compared to forceps biopsy in semi-rigid thoracoscopy. However, there are some scenarios, such as sclerotic pleural mesothelioma or rare tumor lymphoma, in which cryo may be of advantage. Of course, many centers do not use semi-rigid thoracoscopy, use rigid thoracoscopy. In that case, the forceps are significantly larger, and of course the superiority of cryo may not be the case. Some centers are using cryobiopsy to approach the visceral pleural and lung through a medical thoracoscopy approach. But again, this is a highly experimental approach to pleural diseases and to lung diseases. Finally, just to remember that cryobiopsy has been used for 30 and more years for cryorecanalization and endobronchial biopsy, and this is a case of papilloma of the lingula that was resected en bloc with the use of the cryoprobe. So my conclusion, cryobiopsy has been the armamentarium of interventional pulmonologists for decades, and it is still used in central airway lesions. It is now standard and accepted in several guidelines for the diagnosis of interstitial lung diseases, and it is emerging for the biopsy of mediastinal disease and lung, peripheral lung nodules. Of course, for the thoracoscopy, further research is needed. Thank you very much for your attention and for your kind appreciation.
Thank you very much, Professor Sara Tomasetti, for this very nice presentation. And thank you very much for your contribution with us in our conference. Now it's time for our final session, and I call for Professor Nazar. Professor Nizar Rifat, Professor Adil Ansari, and Professor May Saeed. And for the chairpersons, may I call for Professor Muhammad Khairi, Professor Khalid Hussein, and Professor Iman Galal. Thank you very much.